back, everybody. This is Kelly from Revive Naturopathic Medicine, and I am back with Dr. Derek Lawrence and Dr. Brian Myers. Today, we're going to be talking about something called SIBO, small intestinal bacterial growth, which is difficult for me to say, but hopefully for these doctors, they know a little bit more about this topic. So take it away, Dr. Derek and Dr. Brian.
Perfect. Thank you, Kelly. SIBO or SIBO, small intestinal bacterial overgrowth, is a pretty common condition, I think, in both mine and Dr. Myers' practice. And really today I really wanted to take an opportunity to kind of lob this ball into Brian's court, and put him on the spot a little bit to tell us more about SIBO, trends that he sees in it, how he's going about treating it, and we actually have some results that we'll share on this video, obviously with any identifying information hidden, so that you can actually see how we diagnose small intestinal bacterial overgrowth, what the test results look like, and you know how that kind of interpretation will go. I'll talk a little bit about my kind of understanding of this problem and the cases in which I look at testing it for, and usually it's going to involve a lot of GI upset, and these are things like kind of a lot of gas and bloating, right? These are commonly symptoms of SIBO. Heartburn, in fact, we'll look at as well. Constipation can be there as well, but some of the symptoms can even trickle more into folks who have other, what we'll call like extra intestinal problems as well, and I know for sure, Brian, that you'll hit on some of that. So I'm going to kind of pass the intro over to you, and I want to hear kind of your take just on SIBO as a condition. Who's kind of starting to raise flags, or what symptoms start to raise flags for you as to, well, is this person suffering from this, and or how this condition can like manifest in the real world. And then we'll maybe dive into some of the lab results, and I'll see what you have to say about them.
Right. So let's establish a little bit of anatomy first. So below our lungs, in our the core of our body, sits the stomach. From the stomach, we have the small intestine, the duodenum, jejunum, and ileum. The ileum connects to the large intestine, which runs up the right side across our lower abdomen, and then down the left side of our lower abdomen, and out the back side. So SIBO, small intestine bacterial overgrowth, means that the bacteria that typically colonizes our large intestine has, for whatever reason, crept up into the small intestine and caused a bit of an overgrowth there. It's not just for whatever reason. Those reasons we'll get into a little bit later. But those bacteria aren't necessarily pathogenic bacteria. They tend to be part of the gut flora that we want to have in our gut, in our large intestine, but tend to cause a little bit of havoc in our small intestine. They tend to gobble up some of the nutrients that we would otherwise be better served receiving ourselves, and then they tend to produce a fair bit of gas by way of fermenting, or they tend to ferment in our small intestines some of those nutrients, and then that manifests as either the feeling of like a food belly, or a food baby, where you have this like distended abdomen, and potentially some pain from the amount of gas being produced, and that ends up being flatulence or burping, belching, and that's for some people unsavory. For others, still it's downright foul. And is this bad or good? It's not great in the sense that we're missing out on the nutrients that we would like to be providing ourselves. And for some people that can lead to more serious complications down the road. And then there's a range of severity with SIBO too, as there is with most things. And so some people might have underlying SIBO and just not even know it. I just think, I get a little gassy sometimes and that's no big deal.
Yeah, there's, the way I explain to people is I say it's normal bugs in the wrong spot, right? They're generally supposed to be there, but for, factors A, B, C, and maybe even some unknown ones, you got too many in the wrong spot. And, most of my patients are, familiar with either things like kombucha or maybe some who aren't, or beer. But, when you crack that kombucha, you crack that beer, you get carbonation, right? That is a product of fermentation, right? That's what these bugs do. They ferment basically carbohydrates, right, from our food, and then they produce this gas. And when I think a lot of us have maybe shaken up a soda, a beer, or kombucha, right? It just blows all over the place, right?
That explosion's happening in your small intestine.
That explosion's happening, yeah, and
up or down,
right? And that's a totally like digestible way to explain it, because everybody's had either that belch or maybe like heartburn or reflux from that gas, literally causing kind of pressure dynamic issues and causing heartburn. And inevitably someone's also sat in the toilet and had a degree of explosion as well, for one, at one point in time in their life. But some people suffer from this. And I'm sure you've had these cases, Brian. Like, there are some people who like have to plan their day around where's the bathroom.
Yeah. Like we mentioned, these bugs tend to produce a fair bit of gas. That gas can be hydrogen, methane, or sulfide producing. And those tend to kind of manifest a little bit differently. Some people tend towards having a bit of diarrhea. And again, that's where you're literally planning your day around, like, where are these bathrooms? Because I don't know when this is going to happen. And that's just frankly unsavory. And then some people tend a bit towards constipation, which is unpleasant for other reasons. I mean, just not having a bowel movement, for, a day or two or three or even more can be really uncomfortable for some. And there are, untoward long-term side effects from that too, right?
Yeah, exactly on both sides of those, you can actually, like, they're uncomfortable symptoms, but left long enough or severe enough, they can actually be like pretty serious problems. Diarrhea can leave people chronically dehydrated. That's not uncommon. I mean, we can talk about malnourishment later, but that's another component, but chronic diarrhea can certainly do that. And on the flip side of that, chronic constipation, not only can you actually cause tissue changes in your colon, right, where it's actually starting to expand in size, and then it can lose its ability to properly kind of create normal motility. But you can be more susceptible for things like hemorrhoids, impaction, which is basically just like the stool doesn't move out, right? We've had those cases, a little more common in sometimes kids and elderly than general adults, but it happens. And from a more like naturopathic standpoint, one of the things that we know is there's enterohepatic circulation, right? There's literally recirculation of biochemical compounds, we'll call them that, because some are helpful, right? We recycle bile salts, we recycle fluid, and that's important. But simultaneously, all these bacteria also have endotoxin as well. And if we are recycling that, or we're recycling estrogens at an expedited rate, or other kind of toxic stuff that we kind of want out of the body, we've almost secondarily now burdened the body in a whole different mechanism, which can have its whole other gamut of symptoms of, kind of toxicity, overwhelm, stressing our liver detoxification pathways. So you're spot on. It can be simple, or not simple, but it can be less severe, and it can be more, is so spot on, because someone might have a little burping. Another person, it could be the crux of a real complex health issue. We talk about gas and bloating, and I think people can identify with that. But like, let's expand that to say, all right, well, what else? So, like, what other, from a symptom standpoint, because no one's walking around saying, I think I have SIBO. Like, oh, my SIBO's acting up again, right?
No, but they do say, I think I have a food baby after
Yeah,
most meals. And
they
that's
do.
really annoying.
They
I
do,
was
right?
gonna ask, like, how do I know when to come in? Like, how do I know as a patient or someone who's listening to this, know if this is something I should come in to see you guys, or if this is just something I should wait out for a couple days?
I mean, if you're not having at least a bowel, not you specifically, but the whomever, if you're not having at least a bowel movement a day, and you're having, you're missing days between bowel movements, that would be an interesting and noteworthy thing to mention to your practitioner. Also, if you're having loose stools or not well-formed stools on a regular basis, excessive gas manifesting as belching or flatulence is another. I mean, we've kind of like nailed that one down as the most hallmark sign, but I mean, people dealing with migraines, weight loss, weight gain. I just want to hit migraines again and also just say headaches too. Issues with staying hydrated, waking frequently at night, overnight, difficulty sleeping, skin pathology, skin rashes can all, be derivatives of SIBO, or small intestine bacterial overgrowth.
I know, Kelly, I'll share with you a couple of things that I find that I keep my radar open for. And one of them is if someone's missing a gallbladder.
Mm-hmm.
If they're missing a gallbladder, to save a long anatomy lesson, basically stores the bile that your liver produces and then is designed to dump it into the small intestine around meal times. And that helps us absorb our fats, and it also helps us dump other kind of toxic compounds to be eliminated out of our gut. But one of the functions that it also has is it has some antimicrobial capacity as well, and it keeps the small intestine more regulated from a microbial growth. On that same front, I think low stomach acid production is another key component, and we're rolling into causes. But let me give you the symptom that often presents with is heartburn. So that's a real common one that this chronic heartburn cases where they've been on Pepcid, Prilosec, like they've been on something, omeprazole, for 5+ years, right? But was using for 6 weeks.
None of those are supposed to be long-term therapies. And if you've been on those for a long term, then please talk to your practitioner about that. They're not designed to be used in that way. And we talked about fermentation before, and that's, when you don't have enough stomach acid, guess what that meat's doing?
Yeah.
It's fermenting, and it's rotting. And that's, that can lead to all of those things that we talked about.
Right. Yeah.
From diarrhea to constipation. Yeah. Sorry.
Yeah. No, you're good. That heartburn is one of the first ones we'll look at. Burping, reflux, all that kind of stuff. What are the other conditions? It's a very small subsegment of the population, but I have a couple of people who fall in the spectrum. Is the hypermobility Ehlers-Danlos syndrome folks. I don't think I have a case of that without SIBO. And then head injuries. So people who have had traumatic brain injuries, concussions, mild to severe, really common environment for SIBO to overgrow. My theories behind that is some of the most likely some of just the nervous system connection to proper gut motility has been compromised from literally from head trauma. Granted, there's probably a multifaceted mechanism there as well, but those are population bases that I think, if you fall into one of those and you're kind of bloated, or what we'll call like irritable bowel syndrome, right? I mean, like, how annoying is that diagnosis? And
it's annoying because it's not. It's just saying like, I don't know what else to call this, so we'll just call it that and hope that's satisfactory. But it's
right.
not. I think we've found, and I've seen this in the literature, that a large majority of those IBS cases are just undiagnosed SIBO. Not
Right.
just like it's so simple, but they tend to be, and it's at least worth exploring if you've been told you have IBS.
Yeah. And you said it's not so simple. I think that will roll us into what you were commenting on. It's a good next topic, right? So, what causes this? You know, like what do you know causes it? What do you think participates in it? Like, you know, some of my thoughts, like the gallbladder, right, and low HCl. Like these are a little bit more of my thoughts and clinical experiences. But like, tell us a little bit more about that.
Yeah, I think any sort of bowel irregularity or consistent bowel irregularity can be a contributing factor. But a lot of times it's history of antibiotic use or recent history of antibiotic use, history of food poisoning. We've talked about low stomach acid and like the gut-brain connection or disconnection in some cases, thyroid dysfunction on either end of that spectrum could be a contributing factor or a cause. And then since we're talking about thyroid, we might as well mention HPA axis dysfunction. So HPA meaning hypothalamus and pituitary, along with our adrenal glands, and any sort of dysfunction among those important parts of our body. Large intestine dysbiosis, the presence of pathogens can be a cause, even though, you know, we've kind of alluded to that's not always the case, or that these bugs aren't always bad. They can be.
Yeah.
And, you know, that just is a complicating factor then. Gut inflammation in general. So like our people that are dealing with like inflammatory bowel disease or celiac are certainly at risk. Yeah. Do you have other ones? There are more.
Yeah, there are
sure.
more. You know, I think a couple other ones that we should mention is history of food, like food poisoning, right? You know, or you know, acute gastroenteritis. That's, you know, went down, ate this taco, and it just wasn't right, right? And that seems to set off some immunological susceptibility for this condition to exist. I have a large female patient base. Another one is intestinal adhesions. And the reason why I bring out the females on that is that, you know, sometimes they've had things like hysterectomies or
C-sections.
or C-sections. These are surgical interventions that then, of course, you know, need to heal. Adhesions are like scar tissue and like scar tissue connecting from these organs to your intestines, and it can compromise the motility of the proper kind of motility of the small intestine, well, and the large intestine as well. But that is a system that can be set up to develop SIBO. And when we talk about gut motility, I'll take a little aside on here because it's kind of in the causes kind of headline here. You know, some people think of gut motility as, well, I poop every day, right? You can poop every day and have SIBO. The motility that we tend to reference, right, when we're talking about SIBO, is this intricate part of the small intestine called the migrating motor complex. And this is like a component of like the intramuscular component of the small intestine that is designed to like sweep, well, food, but also bacteria out, right? And so when we talk about motility, that is really what we're referencing when it talks to SIBO, is the health and integrity of the migrating motor complex. And I think from you know, we talk about head injury component. I think that is probably where some of the damage comes in on that front. But you don't necessarily need a head injury to have a poor migrating motor complex function. And it's also why laxatives don't solve this problem.
Right? And even herbal laxatives, some of those herbs that we use to have regular bowel movements. You're right. I mean, constipation and the use of laxatives, as well as some of those other things, that migrating motor complex is pretty essential. And like you mentioned, it's kind of like it's a coordinated effort from our muscles to just kind of squeeze everything all the way out and just kind of say like, here we go, let's do a quick cleanse.
Right.
That tends to not occur unless we've been in a foodless state for at least 4 hours.
Mm-hmm.
We tend to have one that occurs in the morning, and those are pretty essential to like keeping regular healthy bowel habits.
Yeah. Well, let's pivot this. I'm going to lob something into your court, Brian. I got test results, and I want your on the spot interpretation of them. So let me share my screen here so you can see these.
Somebody in trouble?
Yeah, I guess so. I wanted to avoid that, so I put my headphones in.
That was the SIBO Police.
That was the SIBO Police. All right, can both of you see this?
I can.
Okay, great. So, our information is hidden here, but so this is Commonwealth Diagnostics. This is a SIBO test. I'll talk briefly about the test and the test collection. It's actually a breath test. So the mechanism that we're trying to capitalize here is on measuring that gas production. So the test involves drinking a little sugary drink made from lactulose. There's different SIBO tests out there, but lactulose is kind of the more consensus of the better one to do. Drink the lactulose, and then every 15 minutes you breathe into a test tube, and your breath is going to contain, and then of course you cap it very quickly, is going to contain certain levels of methane, certain levels of hydrogen. It's going to contain certain levels of carbon dioxide, obviously, because it's your breath. But we look at that and we reference how much hydrogen, how much methane is being produced at these different time intervals. And these time intervals are meant to reflect kind of like where the transit through the small intestine.
Mm-hmm.
And so, this is a test that we're looking for if a person has SIBO. Sometimes either high baselines in gases or spikes of hydrogen or methane, which will reflect too many bugs, hyper fermenting that sugar. Because the thing about lactulose is we can't absorb it as humans. We don't absorb it, but the bugs can use it. Right. And then we breathe in these tubes and we get a reflection of how much gas is being produced. So, I know, Brian, you're familiar with these results. What's going on here?
Well, this looks like a positive result for SIBO, small intestinal bacterial overgrowth. And the reason why we see that is the chart on the left is a pretty handy representation of those time intervals Dr. Derek was talking about. So, we can see that there was a small rise in hydrogen early on, but we see a quite a bit larger rise towards the end of the chart there a little bit later on. And so, as you said, we're trying to approximate moving through the small intestine and then looking for peaks or changes in either of these gases, which would indicate a positive SIBO test. Sometimes they come back and we may, it's possible that there are blooms of these bacteria that are between those time intervals, and that can be a little bit challenging when we're trying to interpret these results. But this test looks to be positive as we see a combined effort from both the hydrogen and the methane a little bit later on. So, yeah, I would definitely consider treating this patient for SIBO, but also would want to take into consideration their clinical history as well.
Yeah.
But that's probably what led to the decision to run this test. So.
Right. Yeah. And I think if if you get the best SIBO minds in the room, that symptoms do matter. Because, and they matter usually more in the cases that are a little more vague, where they're not overtly, oh yeah, like this is rip roaring high positive. Like, okay, like that's easy to interpret, right? But they're the ones where it's like, well, there seems to be a little bit of kind of vagueness in these results and a borderline result, that's where symptoms and treating that human tends to matter a lot more. Well, I will confirm with you. You're like, but yes, also Commonwealth agrees with you that the presence of bacterial overgrowth here is supported. This to me screams of hydrogen dominant SIBO.
Yeah, I mean, you can clearly see that towards the end as we see that huge spike in hydrogen.
Yeah,
Mm-hmm.
and given symptoms, and of course there's no privy to these symptoms as well. One of the things that we commonly look at if we're looking at hydrogen or methane dominance is its higher correlation with constipation.
Mm-hmm.
As you mentioned, that was not present in this case, so it kind of takes another kind of notch in the, all right, well, we're likely looking at this causing a problem. So yeah, I agree with you wholeheartedly on those results there. And this is arguably a patient of ours. And I'll say that because these are actually my SIBO results.
Yeah.
I wanted to say, I generally don't
happens
have
to the best of us.
Yeah, I don't have huge complaints from a GI standpoint overall, but I did notice over this last, and I don't know if this was COVID related or what, I noticed, I was finding myself a little more bloated feeling. I was actually I was waking up just feeling like full at night, and I wasn't sleeping as well. And I know that because I wear my Oura ring. And so I could see like too many wakings at night, and I wasn't feeling as refreshed as I was like, and I was gassy in the morning. It's like, that's so strange. And
were you just waking up, or were you waking because you had to like have a bowel movement?
No,
or
just waking
because you needed to pee? Okay, just waking.
No, just waking up from like almost like GI discomfort.
Mm-hmm.
And so, and if you know anything about me, I value my sleep. And so it was disruptive to me. And I also noticed that over that kind of period of time, I got like less consistently good bowel movements. They were like looser, and that was like I knew something was up. So I was like, well, I kind of intuitively knew, I think I probably have a little bit of this. And I can reflect back on my life and probably said this has been a trend that I've flirted with. We could go all day about maybe why. Head injuries, yeah, antibiotics, yeah, stress, sure, yeah, right. Like, and so this is what I find beautiful and frustrating about this. It's beautiful in the way of like, you can be like, hey, something's wrong, and we can do something about it. But it can be frustrating because it's like 95% of the world is walking around with like 7 major risk factors for developing this.
Right.
And then you throw a global pandemic on top of it. I can confirm with you that these are true symptoms of a SIBO. I'll say a mild SIBO sufferer, because I think that I have my symptoms pale into comparison to some of my other patients.
Mm-hmm.
But they're certainly there, and they definitely have improved since I started doing something about this. And I want to get your take on, well, one, how would you treat this case?
Mm-hmm.
And I'll tell you what I did.
Sure.
And then, we can expand that into, okay, well, this was a hydrogen dominant case. Like, how are you going to treat maybe something that's methane or something that's hydrogen sulfide?
Mm-hmm. There are a couple of different ways to approach treatment of SIBO. I commonly resort to herbal antimicrobial combination therapy.
Mm.
There are a couple of multi-center team formulations that have been researched in the past that can be helpful, but also just assembling a well-rounded herbal antimicrobial combination can be really effective too. A lot of times that would include herbs like berberine and or neem. Sometimes garlic in the form of allicin can be effective. That tends to be more so for methane producing bacteria. So for some people, an herbal approach is well suited. For others, we can use some antibiotics. The specific one that's used for SIBO is rifaximin. The reason why we tend to use that particular antibiotic is because it is specific to the lumen of the intestines, meaning that it doesn't have a very broad spectrum approach, and that can be, that's just better in general, right? We don't want to kill all the bugs all over our body if we don't have to.
Mm-hmm.
There are some drawbacks to that too. Then a third approach for some people can be to use an elemental diet, which is basically food in elemental form over a period of 2 weeks. And kind of the approach there is to starve the bacteria. And that's actually interesting if we talk about treatments. There's some diverging theories there. Some people think starving the bacteria while you're killing them is most effective, and still others think well-fed bacteria are easier to kill. And so, there's a difference in opinion or approach there, and that may be part of the nuance of like treating one person versus another. Always there's a nutritional component to that. We tend to try to avoid those foods that can trigger those food babies or other unsavory symptoms. There tends to be with SIBO a fair bit of recurrence, and sometimes that means just changing up the protocol that was used from one attempt to the next. But also good gut health, regular, well-formed, consistent bowel movements, I think are a big goal and a big aim that I've been coaching my patients on of late for how to kind of resolve this on a more long-term basis.
All right. So Dr. Brian, what am I doing with these results? What are you telling me to do?
I would treat this person, you, with, let's see, I would do some berberine and either some neem or oregano. And I would do that berberine like 1,500 milligrams 3 times a day. And whether you're doing neem or oregano, it would just vary on the dosage of that. If you're doing neem, you do 600 milligrams 3 times a day. If you're doing oregano, 100 milligrams 3 times a day. Mm-hmm. I think that would be oregano. I would do maybe that would be a little bit better indicated for you because there is a little bit of methane there. I think I might just stick to berberine and neem if it was hydrogen only. Yeah. If there was a higher amount of allicin or of a methane, like I mentioned, then using something like allicin, and then there's even another herb that can help, or another herbal blend called atrontinol that can be really helpful for kind of like blunting or minimizing that gas.
Well, let me share with you what I did.
Okay.
All right. I did none of those things. Well, that's not entirely true. One, I use that all the time. I use these results as an opportunity to experiment with some new treatment ideas. The classical berberine, oregano oil, I use it successfully almost all the time with the patients. Atrantil with the methane. So I totally agree with you on that. The garlic, I kind of go back and forth on. Some people tolerate it. Some people don't love, the garlic burp. And
I just want to jump in right there and say, so using garlic, like food garlic, isn't always going to be as agreeable. The sulfur in that can be a little bit irritating to people who are SIBO positive. So I just want to jump in and say, like, don't interpret that as like, oh, great, if I just eat garlic with my food, like I'm going to feel better, because you might actually feel worse. It's
much worse.
Specific chemical constituent from garlic called allicin that's got some nice antimicrobial properties, and that's what we're using.
Right. Yeah, that was a great clarification. Pretty important there, because like
they said garlic. I feel like
right. Yeah, I ate a whole bulb of garlic every day, and now I got like a huge food baby. But I agree with you on all that, and those are things that I commonly will do. So from an herbal approach, and I'll take that just in isolation. We can take this screen share off. From an herbal approach, I actually experimented with a kind of a combination herbal tincture of a mixture of berberine, like you mentioned, myrrh, and thyme.
Cool.
So I made that. Tastes not good, but I took that a few teaspoons, a couple of teaspoons 3 times a day. I also combined that with an herb called uva ursi,
Mm-hmm.
and took that at a similar dosage, and some Argentin 23.
That's
And
colloidal silver, just for the
silver
whomever
hydrosol
didn't.
to be more specific, but yeah, in that realm. Yeah, so I decided to kind of try out a protocol, and part of the reason why is I wanted to expand that treatment outside of hydrogen into a little bit of some biofilm disrupting, and that's probably a topic for another day. But also to cover a little hydrogen sulfide as well. The piece that you don't know about that is I do have some GI map results from diagnostics that had some, enlightening information on some of the families there. So, I'm kind of withholding information here, and I know that's not fair, but that's why I chose the treatment I did. What I hope that illuminates, though, right, is that there's like this, I want to say standard operating procedure, but there's these things that we know that work. But when you start to like understand the human who's sitting in front of you, and you get maybe more data or more symptoms, you may have to stray away from that box and say, this is actually much more indicated. And of course, you pay attention to their symptoms, their improvements, and then, retest them to make sure you are accomplishing.
Like a good scientist.
Like a good scientist, yeah, accomplishing those goals. A couple of the other things, not only that, I focus on myself, but these are things that I emphasize with my patients. 2 to 3 meals a day, no snacks. Yeah. And I say 2 to 3 because, some of my patients do time restricted eating or what other people call intermittent fasting, and they don't eat breakfast. So they kind of only eat twice a day. So, all right, well, I'm not trying to force someone to eat 3 times if they're only eating twice. And it's something I do relatively routinely. So I'm only usually eating two times a day, but no snacking. And the mechanism behind that is to stop like drip feeding the small intestine with food, to actually give that migrating motor complex, like you said, that opportunity to fully pulsatilely remove that food out of the small intestine.
So a reasonable aim or goal would be 4 hours between those meals then.
Yeah.
To help that migrating motor complex action.
Yeah. So that is something I often recommend from a food behavior standpoint. Obviously, the normal food hygiene of chew, don't drink a ton of water while you're eating. Don't guzzle a big gulp while you're also trying to eat your
ever.
I more so meant like a big gulp of water, but yeah, I guess a big gulp of soda would be bad too.
There's never a good time for that.
Right. That normal food hygiene stuff I think is important. I personally will occasionally use digestive enzymes to better facilitate breakdown. I think these are useful to use sometimes in real stressed out people to kind of cheat the system a little bit. I don't love the idea of using them long term if we don't have to, but there's a time and a place, right? For some of the maybe gallbladder missing people, we'll entertain using some ox bile as well to replace that. And that's from like the beginnings of digestion to the food habits to the meal timing. I think that's what we use. I emphasize a low carbohydrate diet. I know you're kind of in that same ballpark as far as treating SIBO there. It's just removing the source of
fuel.
Yeah. So that you talked about starving them, that, I think there's a balance there of like making sure we can eat sustainably, right? That we feel good, get enough energy, etc. But simultaneously, try to minimize the bugs. And so from my case, I generally maintain a relatively low carbohydrate diet, though I will say up until this, it was a little heavier than I normally,
you must have been adding some fuel to the fire here.
No question, I was, and I have choked that fuel out. And not only do I feel better gastrointestinally, I feel better. Full stop. End of sentence. And I know I do. So, It might be also, Brian, why I love, and Kelly, you're part of this too, why I love fasting. Like maybe that's a component, because I always generally find it easy. I generally find it easy. I feel pretty good. And it's not unreasonable to think that a component of that is, I'm stopped poisoning myself on a routine basis with, small intestinal bacterial overgrowth.
A pathology of excess, you might
Right.
say.
Yeah. Right.
Yeah. Did you find fasting, and this may be more of a topic for another day, I think it is, but just, you mentioned that fasting tends to be easy for you, and I just want to, was it easy the first time you did it?
Yeah.
Okay, cool.
Yeah, it was. I mean,
not always the case. So
yeah, I've had harder ones, but I think that, I think it's just, I don't know, it's something that I can just like wrap my head around really well. And mentally, I don't find it that hard. I love eating and I love cooking, and I miss chewing when I'm fasting. But like, other than that, I don't think I really don't miss food. I find I have valuable and sustainable energy most of the time. Sometimes getting into one like day one, it's a little rough, but that picks up really quickly.
Yeah, like day 2, day 3.
Yeah, but that's
like
just me, and I think
different kind of
Kelly,
clarity.
I think you can, you moderate some parts of our fasting group there. I think that's the exception and not the rule. Hey.
Yeah, well, and we can also ask you that during a fast and not after.
Yeah, right.
You're not hungry. You're not hangry right now, are you?
Right. I think that maybe if we went back and watched some of my literally in the middle of fasting videos, people might be calling BS on me.
Yeah.
I'm not entirely sure, but when I reflect on them, I can reflect on them fondly. So that must mean they're not miserable.
The outcome creates a space for gratitude.
Right.
That's noteworthy.
Yeah. So, Brian, we hit on this a little bit with this migrating motor complex, but I want to focus on one thing in particular from a motility standpoint, because pro-motility agents or optimal gut motility in that small intestine from a migrating motor complex standpoint is arguably crucial, and the crux behind this being a successful treatment or not. And there are medications that support this. There are herbs that support this. One could probably argue stress and stress reduction and overall improving gut health is going to play a large role in this. But you use a certain treatment called LDN, or low dose Naltrexone, not only kind of through this lens, but also through a bigger picture lens. And I just want to hear, again, might be a bigger topic to talk about later, but I just wanted to talk about the usage in it for SIBO, and then a brief little, what's the general population that's actually using this medication?
Yeah. So like I mentioned earlier, regular, consistent, well-formed bowel movements is a goal for SIBO treatment. And part of that means having good motility. Supporting the migrating motor complex is part of that. And there are some agents that we tend to use, particularly in our patient population, that tends towards constipation, but not just limited to those people. Low dose naltrexone is the off-label use of naltrexone. Naltrexone itself is an opioid antagonist, so it's used to help people with opioid addictions. It can also work for people that have, in a positive way, for people that are struggling with alcohol use. But those are topics for another day. When we're using the low dose form, we're using 1/10 to 1/100th the strength of standard naltrexone. And it seems to have some really positive benefits on overall gut health. The theorized method of action is that it blocks our opioid receptors for just long enough to promote an increase in our own endogenous endorphins. And that has a positive effect on a number of different levels. So LDN can be a nice immune modulator for people struggling with autoimmune conditions and or cancer. And it can be a positive for people that are struggling with mood disorders as well. The range for LDN is wide, but the specific use for SIBO is as a mild motility agent. So it does function well as a mild motility agent, and that can be really helpful for people when we're aiming to get those regular, more consistent bowel movements than like once every couple of days or even, once every other day. It can be really effective to help have more consistent bowel movements. It's typically taken in the evening, just prior to bedtime, and that can help again with that migrating motor complex while you're sleeping, to help form a well-formed bowel movement in the morning.
Yeah. So it's like a unique medication. And most of my patients know I don't like just jump to, hey, I suggest you take this medication, but this one has a lot of value in a lot of different realms, and like through this lens of SIBO, especially because it can present itself in more complex cases with anxiety or with depression or with autoimmune. Like it does, just you can have SIBO and these other things, and there's some one could call them side benefits, and that's one of the things I say about a lot of our therapies here is we try to use certain compounds that are going to have side benefits. Yes, they're going to help the problem that is taking up the most room on your plate, the thing that sucks, but it's also going to have a web of positive effects on your system, ideally ones that you can feel, and some that maybe are kind of behind the scenes treating something objectively.
Yeah, there's some other nice benefits to it too. In addition to like all of the like wide-ranging positive benefits, the buy-in is relatively low in that there's very little risk, to no risk using this medication for even a short-term or a long-term period of time. The half-life is relatively short, so it washes out of your system pretty quickly. And the biggest complaint I've experienced, and that is reported, is more vivid dreams. For some people, that's fantastic. They love dreaming, and they like it when it's more real life like. Yeah. So for those people, great. And then there's easy workarounds for people who are struggling with that, or some people experience a little bit of vertigo, or there's easy workarounds for those. And like I said, the risk is there really isn't any unsavory side effects other than those kinds of things. So
yeah. Perfect. Well, I'll end this, to make sure we respect everyone's time, but I'll end this in saying that SIBO is a pain in the butt, literally and figuratively. And I think we got to some reasons as to why it can be, because it's so multifactorial. It is dealing with microbes that are normal. They're supposed to be there, but just not in that amount. So it's like you're not looking at eradicating a pathogen. And once it's gone, great. It's this gray area, this balance. And I think that, I think that's why maybe us naturopathic doctors are the ones that tend to see this and understand this, because like we operate in this gray area, but it's not like black or white. It's this problem. And because of its multifactorial nature, its relationship to stress, or potentially, food poisoning, or potentially, structural abnormalities and nervous system dysfunction, there is a degree of relapse that can happen, and that's frustrating. But I think that is an important piece to bring up right at the forefront, that this is a chronic challenge that we're going to have to learn how to understand and help you figure out how to operate with. But, this conversation we got to have today, Ryan, was great. I think that we hit on some other like real reasons why this problem kind of exists, and, illuminated those pillars that we got to be paying attention to, whether it's food or food timing or stress, or understanding our own medical history and how it can create an environment that might be susceptible to this, knowing the symptoms that we should be paying attention to. So if you're struggling from, A, B, and C, maybe I have SIBO, and then maybe I want to sit in front of someone who knows what that is, and then what to do about it, and also how to individualize it, because we already talked about today how there's, a handful, almost a plethora of different treatment approaches for this, to fix that. So I want to thank you for sharing that with our audience, and Kelly, from your perspective, anything else we need to kind of wrap up with? Do you have a better understanding of SIBO?
Yeah, actually, it definitely answered a lot of my questions. But I also just wanted to say, if anybody has any further questions about SIBO or about any other of the treatments or things that have been talked about today, you can find on our website, there is a request an appointment section at revivenatmed.com. You can also find us on Instagram and Facebook. And we also have a free 15-minute consult that you can talk to any one of our doctors.
Yeah, and look forward to having a couple more of these with you, Brian. And these are valuable opportunities to just bounce ideas off each other.
Yeah, this was fun. I look forward, like the list of other ones we could do.
Right.
It's easy to make.
Perfect. Well, thank you both, and have a good rest of your day. And for anyone who watched this long, thank you.
Yeah, thank you. You made it to the end. Congratulations.
Made it to the end.